Welcome to the Pharmacists Are In, a podcast made for pharmacists by pharmacists, hosted by John Papasturjo. John is a frontline community pharmacist owner, assistant professor at the School of Pharmacy at both the University of Toronto and University of Waterloo, and an internationally recognized speaker, author, and researcher. Today's guest is Dale Griffiths. Dale has been a community pharmacist in New Zealand for over 40 years. He has been actively involved in both pharmacy governance and education. He has been a panel and committee member at the University of Otago and helped with setting up the University of Auckland Pharmacy School in 2000. Dale was also the chair of the College of Pharmacists in New Zealand and the past president of the Pharmaceutical Society of New Zealand. Join John and Dale as they talk about a wide range of topics, such as the expansion of pharmacy's scope of practice in New Zealand, the political debate surrounding drug reform, and the shifting global medical landscape. Listen in as they also discuss INR point-of-care testing, which is a new practice area for both Canadian and New Zealand pharmacists. Tune into the successes and challenges of implementing INR clinics from two experts in the field. Pull up a seat and let's get started.
We're here live from the 78th FIP, World Congress of Pharmacy and Pharmaceutical Sciences. I'm here with Dale Griffiths, and we've really excited, Dale, to have you on the show and be able to chat a little bit. Yeah, we've been coming to this conference for a few years now. I had a chance to meet Dale back it was probably before South Korea, I think.
First time I met you was in Vienna.
Vienna, yeah. So this is one of the unique things about being involved in pharmacy practice globally. You get to meet interesting practitioners, researchers, educators from around the world. And Dale has done a lot. He's from New Zealand. Dale, maybe start by telling me a little bit about what you've done in your past.
Sure. I've been a community pharmacist for nigh on 40 years. I did a small stint in hospital, but I've been involved in pharmacy governance and education. So I had roles at both universities on different panels for the University of Otago and helped with the setting up of the University of Auckland Pharmacy School in 2000. Also, my time I've been chair of the College of Pharmacists in New Zealand, and I'm a past president of the Pharmaceutical Society of New Zealand.
How many pharmacies in New Zealand?
There's about just short of 1,000 community pharmacies in New Zealand.
So you represented a good chunk of pharmacists there as well.
Well, all members of the society, all pharmacists have to be members of the Pharmaceutical Society because it runs the only accredited CPD oversight program in New Zealand, which means there's a lot of resource gone into developing it and supporting members and pharmacists to do good CPD.
It's always interesting here at FIP, you kind of get down here and you know, pharmacy, you kind of live in a bubble when you're in your own country. I mean, you practice within the jurisdiction of your country, and then you get out here and you see how much variability there is. Especially in the countries that are really now starting to promote the profession. They're looking towards, more advanced pharmacy practice and seeing what they could pick up from us. But I'm sure we'll meet a lot of them today at the welcoming ceremonies and whatnot. But New Zealand I consider it one of the countries that's more advanced with respect to pharmacy practice.
Yeah, thanks, John. When you come here, it does put it in perspective. I know at one of the other IPACT events that I went to in Oslo at EAHP, talking to pharmacists from Europe, and we're talking about doing the warfarin management and just some of the things that we do as pharmacists in community with patients, they wouldn't ever have thought possible. So it kind of puts everything in perspective for yourself, and you come away going, yeah, despite all the day-to-day angst that goes on around contracting, around grumpy patients, all those things that we all deal with every day, to come out on a world stage and go, this is what we do, and other people go, wow. And I went home really charged up about that. There were a couple of guys from Switzerland that were going to come visit me in New Zealand as a result of that. One Norwegian guy says, I've learnt more talking with you over the bar than I learnt in a whole 3 days at a conference. So that made me feel pretty good.
Yeah, that's one of the good things about FIP. There's a lot of talking around the bar, I find, but it's a good chance to network. But with respect to, practice, do you guys have immunization now in New Zealand? Do you have some of these other things, minor ailment prescribing?
We don't have, we've looked at obviously quite closely at the Scottish model, and Harry McQuinlan, who was head of Pharmacy Scotland about 15 years ago, we brought him to New Zealand would have been 2005, 13 years ago. We brought Harry McQuinlan to New Zealand specifically to look at what was happening in Scotland and the ability of both the government and the profession to work closely together to make sure that the government got what they wanted out of pharmacy and that the profession got something out of it too. And I think that lesson, certainly in New Zealand, hasn't been taken on as well as it possibly could have. We've just been through a contentious new contract round and the vision wasn't there. It became an argument and we all want to get to the same place, but the clarity wasn't on both sides of the argument, and I'm standing outside the argument, so I'm not there firsthand anymore. But that certainly seemed to come through, that there was a disengagement about everybody wants to move forward, but the how-to isn't there.
Yeah, it seems that's a common theme. Like, it depends, I guess, where the country is with respect to practice, but we've seen it as well in Canada. You know, we got pushback with immunization, started with flu. We did a bang-up job with flu, you know, nationally, millions of flu shots now given across the country. Then we get enhanced immunization, a little bit of pushback there, but then that's adopted. And I imagine a little bit that happens everywhere. It's once you get that scope, I think then everyone says, hey man, pharmacists could do a good job here. And
I think, yeah, and you're right. We had the same thing with flu vaccination, and I don't do vaccination, and it's purely a matter of space in the pharmacy I run, or one of them, where it was only those people who weren't covered under the public system that, you know, community pharmacy provided a quick service. There was no appointment needed. You could come in and as soon as a pharmacist was free, they could take you to a consult room and give you your vaccination, and away you went. Then with pressure in a certain geographic area, suddenly the funding came from the government and some of the restrictions around age came off. So people over 65 are all funded in New Zealand for flu vax. Children with certain illnesses are funded, so asthma, type 1 diabetes get funding. And so that's broken some of the barriers, and I think we're still on that journey as to where pharmacy can go with that. We also have to be careful that we're not too restrictive. We want safe practice, but we're also really good, I think, as a profession, because we're so used to a yes, no, it's right or it's wrong attitude from our dispensing practice that we can take that forward too much and actually inhibit our own abilities to move forward.
Well, absolutely. I see that in the students as well. And I think you're very right. It comes from the dispensing side of the business where it's either right or wrong. And the clinical practice isn't always like that. So you've got to get used to being a practitioner as well, where you use your clinical judgment and there is some room for gray, but I think that's something that will develop with time. But you know, you are a business owner as well.
Yeah.
Is drug reform hit hard in New Zealand? I know in Ontario and in Canada, we've seen a lot of drug reform over the last few years, which has almost changed the dispensing business as well. Is that a reality for you guys?
Ours has been a reality for New Zealand since about 1996, where we have obviously a socially or government funded health system, and the government realised that it could start to use its clout as a buyer to reduce the price of pharmaceuticals. So I think at that point in time they were looking at projections of almost doubling the drug budget at current prices within 10 years. And steps were taken to buy centrally, which was kind of happening, but not aggressively. A lot of companies for generic medicines, each brand comes up, or each chemical comes up for a contract, so every 2 years they come up for contract for a sole supply for the whole of the country for 2 years. On the whole, as a taxpayer, it's worked really well. It's taken nearly all the profit out of the medicine out of pharmacy. It's around, you get paid for the service, but there's still a stock holding component. It's kind of recognised, not very well, and there's still arguments around that. But as a taxpayer, it's worked really well, and it's meant the same amount of money is bought a lot more for our country. It has been exposed to some political campaigns that might have been stimulated by the drug companies. Herceptin was a big, it wasn't funded, and then suddenly there became a breast cancer survivors awareness group that made a lot of noise about the value of Herceptin. The buying agency said the evidence isn't there. Obviously that's changed now, where the HERS2 positive obviously responds really well to Herceptin. So it's part of it's been time. Then the then Prime Minister, or before he was Prime Minister, waved it as an election flag, and it suddenly money was made available to fund it. Okay. But we've seen more and more of the biologics start to roll out. There's currently a bit of politicization around some of the new cancer agents, and again, the argument is they're not out there long enough to show us good long-term studies of how valuable they are. The cancer groups are obviously agitating for easier and quicker funding for them.
Well, that's the reality, I think. Well, most of the new drugs are biologics now, and the costs are enormous. So I think everyone, I guess it's a global thing now, trying to balance cost versus effectiveness versus savings and all that. But I think it's a reality now of our profession as well, kind of struggling with all these things, and at the same time trying to reinvent ourselves. I know, we've talked a lot about your CPAMS program, and I think that's probably, when I think about an innovative program that's really changed the way pharmacists practice, that's definitely one of them. Tell the listeners a little bit about that.
It followed a trial one of my colleagues, Ian McMichael, had done in his pharmacy, where they were using an INR meter to check people's INRs, and I'm not sure whether at that point they were actually adjusting doses or not, but they were doing finger prick testing because it was quicker and easier and nicer for the patient than venipuncture. It led to a trial in 2010 with support of Roche, because they provided the meters with the support of the Health Workforce Fund. They were looking at new roles for health practitioners on the basis that there will be more patients per health practitioner, and that the professions were not going to grow at the rate that the people were going to grow at, particularly the baby boomers, as we all enter our retirement phase and our end of life phase. So they were looking at being innovative around the use of the personnel that they had, and pharmacists are seen as a young profession, whereas general practitioners in New Zealand are certainly seen as an ageing profession. There's a gap in the GPs coming through of the 40-year-olds. It wasn't as attractive, and there weren't as many coming through, and there's also much more corporatisation of general practice in New Zealand as well. So lots of factors fed into that. So we ran a trial, 15 pharmacies, and we were aiming for just over 690 patients. We got around 600 patients, and what we proved over a 6-month trial was that we had TTRs of 78%, and that was pretty universal against all those pharmacies. There was a maximum of 50 patients per pharmacy. Not everybody quite got there, which is why we didn't do the 690 for the power we wanted. But what it did was it was enough of a stimulus for the then Minister of Health to go, I want this to happen, because the funding bodies weren't prepared to pick it up after the 6-month trial ran out. So the funding money was there. The Minister said, I want it. And so it was sustained for a short time in the pharmacies that were on the trial. And with that impetus of the Minister of Health saying something, it got rolled out and expanded slightly. So there's now around just over 150 pharmacies providing the service, so not everybody does it. It is targeted geographically to a degree so that there's an even spread of the pharmacies providing it. And what we've been able to show is that we've been able to sustain really high TTRs. So I presented some data last year at FIP. Over 2 separate 6-month periods, we had a time in range of 73.1 and 74 point something low for over 7,000 patients.
Wow, that's incredible. So you got the convenience, the accessibility, awesome results there. I mean, if I'm a patient, that's what you want. And I think that one of the areas of interest in my research and kind of what I do in practice is around point-of-care testing. Challenge we've had in Ontario is a little bit, it's been around the jurisdiction and the legislation, if you're able to do this type of stuff in pharmacies, and it's almost a gray area. But it's great to see that the health minister backed you up there. And
we were lucky, John, in New Zealand that we were able to get round legislative barriers of pharmacists adjusting doses by using a piece of legislation called a standing order. And it was designed for nurses to be able to adjust or give prescription medicines to patients in rest home environments where, say, if a patient had a UTI that was proven on dipstick, that the nurse had a protocol to follow, the doctor signed it off, and these are meant to be reviewed annually. So we used that in a way it probably wasn't perceived for pharmacists to change the doses of warfarin. So as long as patients have an INR between 1.5 and 4.0, we can adjust the warfarin dose as we see fit. Yeah. If the patient's outside that range, obviously below 1.5, it might be initiation. They may have stopped it. All sorts of stories get told around that. But above 4.0, we have to refer that to the GP. Most of the time, if we go to the GP and tell them, because we've learnt through process that the patient doesn't have a history of bleeding with high INR and isn't currently bleeding, they'll let us self-manage that according to the algorithm, and really, reality the haematologists say don't worry until it's much over 6. One of the interesting cases we had was a lady in her mid-60s, quite with it, and had been through a course of cancer therapy, so we've been quite careful around managing her INRs during that treatment. And she came in one day, and it was just a vague comment when I did a test, and her INR was up well above 4. And she made a comment, I'm still eating greens, and it was just the way she spoke that made me think something's changed. And so I said, what are you eating? And she said, oh, peas and beans. And she said, what were you eating? She said, oh, I said, spinach and kale. And she'd gone from products that have 1,000 microgram plus per cooked cup to 60 micrograms per cooked cup. So this huge multiple fold variation, and it pushed her INR up. So most of the time we're actually able to trace, I suspect around 70 to 80% of the time people go out of range. In the conversation we have with them around their management, we can find the source of that. But there's much less, that was far more of a factor in the volatility of people's INRs than were drug interactions. We have had one spectacular case of a drug interaction that shouldn't have happened. But beyond that, most of the variation is actually around food, alcohol, seasonal parties at Christmas and fatty foods.
Yeah, that's what I found too. I I used to manage the anticoagulation service in long-term care at Sunnybrook Hospital. That was one of my jobs when I practiced in hospital. Same thing, pharmacists there. We did all the INR dose adjustments with warfarin, and that's what I found. Occasionally these patients would go home, right? They'd go on passes. We'd have them stable, they'd go home, and that's when their INR would get wacky, and they'd come back, and it's just their diet, drinking, doing other things, but rarely did we have challenges, when there wasn't these dramatic changes, outside of when they got sick. I found when they got sick, that shot it up quite a bit as well, and we had to be cognizant
people
of that.
sick, they don't eat for a couple of days,
That's it, yeah.
and their INR gets out of the way. So we're always giving, I think it's a case of re-education. We had them in a consult room for 10 minutes while they were talking to us about their INR, and we're waiting for the meat to count down. And so there's an opportunity to refresh their knowledge about warfarin and what it was used for, and also for the other medicines they were taking. One of the really spectacular outcomes, we had a video that's available on YouTube that we show to patients regularly, and it's a graphic of around anticoagulation, and somebody at the end of it was just said to me out of the blue, said, that's the first time in the 7 years I've been taking warfarin, I know why.
Wow.
So we assume an awful lot that despite all the telling that gets given to patients, sometimes they just don't get it, and it's a huge amount of trust that's involved. And these are people that have the red warfarin booklets and have education when they put on warfarin, and yet sometimes it just needs a different format to make that.
You know what, you bring up a good point. I've noticed in Canada, one of the challenges now, we've seen a lot of patients transition from warfarin to the DOACs, and I think you've just gotten a DOAC, you were saying, but these patients were used to being monitored so closely because of their INR, they flip over to the DOAC, and we've had examples now, the adherence drops off because no one's watching them. Cases of strokes in the ER just because patients stop taking their medication. I had a senior call in one time, and he's like, you know what, I'm not being monitored, I'm afraid of my potentially bleeding. Yeah. I'm gonna half my dose. I'm like, you can't half your dose, but you see this, and I think you're very right. Sometimes we assume the patients know more than they actually do. Were the physicians receptive to this? You seem like you guys have a pretty good collaboration.
We did, and I suppose it was led by a couple of guys, the senior partners in the practice, who I have good relationships with, and there was, when they agreed, all the other doctors came in line, and since then, obviously, other colleagues have sometimes found it difficult to deal with the doctors. Others, obviously, the doctors have heard of the service and are more willing to accept it. It was difficult when I was asked to speak at a GP conference around this, because I couldn't get one of the GPs I work with to speak to me and stand alongside me on stage, despite the fact he said, you're really welcome to the work because you do such a better job. And I think that was a bit telling, that they don't like someone standing up in front of maybe flying an unwelcome flag. But to come back to the adherence issue, what we found is that well over 90% of our patients present within 1 to 3 days of due date, and most of our patients, the average test frequency in New Zealand is about 1.6 tests per month per patient.
That's awesome.
Which is really good. So we're maximum normal dosing frequency is 28 days. We're not meant to go beyond that, but obviously sometimes with holidays we do that. We had a patient that went to the States who thought it was all good because his daughter's doctor would look after him in the States. When he got there, he found that to be able to be managed by his daughter's doctor, he had to have a full workup, despite having letters from cardiologists and his GP here in New Zealand, what the conditions were. But for basically insurance purposes, the doctor in the US had to do the full range of tests again. So what he does now is he goes to the States, he takes an INR meter with him, and he just emails back results, and we have a chat.
Yeah, and I love that you guys have the data, and I know you've presented on this in the past, but more pharmacists, we got to start doing this as a profession. And I know it's starting to prop up in the point of care world. We've had, I think, INR warfarin data for a while. We're seeing it now with strep, lipid screening, flu testing, pharmacogenomics. There's great push for evidence in the pharmacy world. It used to be done in small pockets, I found, by researchers, but we're seeing more and more community pharmacists, get behind it. And that's really, I think we really need that to kind of keep, that envelope. We got to just keep pushing and pushing.
We've got to prove our worth, and we all assume sometimes that we do a good job, but when it's written in a paper that you've done a good job.
Sure.
We did some other things that have come out of IPAC was the AF screening we're doing, and the first time we did, the very first patient we did, the first time we did the AF screening, this gentleman who I'd known for the best part of 20 years came in, and one of my pharmacists came out and can you just check this pulse because it doesn't feel right?
Yeah.
And so I went in and I said, well, I'm not sure what it is, but it doesn't feel right. And I have obviously felt over time people with AF and felt their pulse. And it didn't feel that thready, gallopy type pulse, but it just felt weird. But an hour later, one of the GPs came down from the practice upstairs and said, well done. He had asymptomatic, undiagnosed AF. So
wow, from a manual pulse check, that's amazing. And you mentioned IPAC, and I think some of the listeners may not know what that is. So that's how we actually met. It's a group of pharmacists, academics, researchers that have been brought together from all over the world, really with a focus on anticoagulation. And kind of expanding the pharmacist's role. And we've got I think we'll be talking to some other members throughout the course of FIP here, but that's been a unique experience because rarely do you see a group of pharmacists from all over the world come together for one therapeutic area.
Yeah, and it's been, personally it's been really rewarding, and I've got my name on a couple of papers that I helped contribute to, which is kind of cool, but something I never thought would happen. But I think also it's the sharing aspect of it, the fact that New Zealand's a long way from anywhere, and it's a 20-odd hour flight to get here. But it's important to be here. It's important to say what we do, not only what we do in New Zealand as a collective, but what we've contributed around the world. And we're finding that 1.4% of those people that we are testing pulse on have got AFib, and they're not diagnosed. So collectively, through the work of us as IPAC encouraging other colleagues to get involved, we've made a difference.
Yeah, an absolute difference. And if IPAC exists, if it doesn't exist, the relationships we've built and the network that we've created here, that'll be long lasting. The ability for our students to connect now. I know we're all collaborating on a pharmacogenomics paper. We're going to launch that project in a few months. Just we've now taken an entirely different direction even. So I think a really unique experience. I don't think many pharmacists have that opportunity, but we've almost built a global network, and we're able to access it for really whatever we want. And it could be our own personal projects or whatnot. And then having also access to the expertise on this committee, because it's not all community pharmacists, it's a mix of everything. So I think we all draw on each other. But it's been a wonderful experience for me. Having the opportunity to meet people like you, Sotiris, really helped mentoring me through my own career has been a great experience. Philippa, and she's really taken charge of the research aspect. It's really been a great time, and we joke about the air miles, but me and you come probably from the furthest distance. I think we've got some people from China.
I win.
Yeah, you win.
I win every time.
You get the good flights too, but I think overall it's really great experience, and I think hopefully we get an opportunity in the future to showcase more of our great work. Thanks for taking the time to come in today and just chatting with us. I know it's just the beginning of FIP, so I know me and you will do the rounds probably tonight and over the next few days, but thanks again, Dale, for coming in.
You're welcome.
This podcast was brought to you by IPACT, the International Pharmacist for Anticoagulation Task Force. Visit www.ipact.org for more information.